Ladies and gentlemen, for time, may I please crave the indulgence of our distinguished lecturer to stand at this point. It's time to introduce our guest lecturer, who will do that electronically by watching his citation. The citation of the distinguished lecturer, please.
Distinguished ladies and gentlemen, I present to you the citation of Professor KAYODE Thaddeus IJADUNOLA. Professor Thaddeus IJADUNOLA is a professor of public health and community medicine with 30 years of national and international experience, 25 of those as a faculty at the Obafemi Awolowo University Ile-Ife. He holds an MBCHB degree of the Obafemi Awolowo University Ile-Ife, a master's degree in the sociology of health, a doctor of medicine degree of the National Medical College of Nigeria, and a fellowship of the West African College of Physicians in Public Health Medicine. IJADUNOLA rose through the rank of the Obafemi Awolowo University to become a professor of public health in October 2011. Besides his university tenure, he is equally a consummate researcher, administrator, practicing physician, trainer, project advisor, and a multidisciplinary consultant. He has continuously been involved in the training of undergraduate and graduate students for upward of 25 years within Nigeria and across West Africa. IJADUNOLA has also served the university in various administrative roles till date, including as the head of the Department of Community Health 2008 to the year 2011, Director, Institute of Public Health 2015 to the year 2017, and Provost, College of Health Sciences 2017 to the year 2021. Professor Thaddeus IJADUNOLA had consulted widely for several government ministries, departments, agencies, as well as major development partners, notably the Federal Ministry of Health, Federal Ministry of Women Affairs, the WHO, UNFPA, UNICEF, the World Bank, DFID, USAID, and the Ford Foundation, just to name a few. Professor IJADUNOLA is widely traveled and published in major peer-reviewed biomedical journals and periodicals. At various times, he was visiting Gate Scholar to Johns Hopkins University, Bloomberg School of Public Health 2004, and Scholar in Residence at the Harvard University Chan School of Public Health, Cambridge 2013. In 2014, he served as research advisor to the Sub-Saharan African Regional Community Health Department of the Shell Petroleum Development Company, Nigeria. In that position, IJADUNOLA led the multinational company's 2014 Ebola control response and support the government of Nigeria for the rapid control of the epidemic. Again, in 2020, he was invited as subject matter expert as the Ford Foundation epidemiologist to the 18-member ANAP Foundation national think tank of eminent professionals on COVID-19. The think tank has continued to offer timely advisory service to the federal government of Nigeria on the possible intervention and scenarios for the effective control of COVID-19. Within the university, Professor IJADUNOLA has served either as chair or members of several statutory and ad hoc committee panel over the last 15 years. He was the pioneer vice chancellor of the University of Ilesha, Osun State, 2022 to the year 2023. And between January 2024 and June 2025, he served as a vice chancellor of Elizade University, Ilaramokin, Ondo State. IJADUNOLA is married to Professor Masliana Inyade IJADUNOLA, another public health physician, and between them are lovely kids. Distinguished ladies and gentlemen, I present to you the Professor of Public Health and Community Medicine, Professor KAYODE Thaddeus IJADUNOLA.
Thank you so very much for that introduction. I'm so grateful. Members of the Executive Council of Ondo State that might be here, members of the State executive, legislative, or judicial councils, as the case may be, the Pro-Chancellor and Chairman of the Governing Council of UNIMED, the other members of the Governing Council that may be here, the Vice-Chancellor and other principal officers of the university, deans, directors, and heads of departments, professors, and members of Senate, members of the congregation, other members of staff and grade students of UNIMED that are here, the members of the Akinkugbe family, both nuclear and extended, and the friends of that family for that matter. My Lord, spiritual and temporal, our online participants, gentlemen of the press, distinguished ladies and gentlemen. Let me start by saying that I'm highly honored to have been invited to give this distinguished lecture in honor of a great medical icon and pioneer and a distinguished Nigerian. The late Emeritus Professor Oladipo Akinkugbe. This in the lecture series instituted in his name. I want to thank the entire university leadership for this rare privilege amidst the list of experts across the length and breadth of this country that are qualified to take this role. I've been long associated with UNIMED since the days of the first Vice-Chancellor, Professor Friday Okonofua, to his successor, Professor Adeshegun Fatusi, and the incumbent Professor Ebonade Jigbe, often visiting either as an invited guest to some past guest lectures or to facilitate some institutional research activities, and lately as a visiting Vice-Chancellor at least 2 previous university convocation ceremonies. This is, however, my first invitation as a guest lecturer, and I bring you warm greetings from Ile-Ife, the source of all good things, and from the great Obafemi Awolowo University. Incidentally, all the past and serving Vice-Chancellors that I mentioned have been graduates of the Obafemi Awolowo University College of Health Sciences, where I currently serve as a faculty member and also hold my chair. Homage to the late Professor Oladipo Akinkugbe, CFR, CON, National Order of Merit, Fellow Academy of Science, and DSC. It's on record that Emeritus Professor Oladipo Akinkugbe was the first Pro-Chancellor and Chairman of the Council of the University of Medical Sciences, Ondo, and the university has done very well to institute a lecture series in his name. There is really nothing too much to do to immortalize the ilk of Professor Akinkugbe for their selflessness and intentionality to chart a course where there was no pathway at the beginning of the journey of medical education and the formal health system of Nigeria. I will therefore start today by paying homage to late Professor Oladipo Akinkugbe, his work, his legacy, and his family. Although I did not have the privilege of being taught by this medical icon, and I only met him once in person during his lifetime, but as a medical student and later practicing Nigerian physician of my generation, the name Akinkugbe rang loud in our orbit in the course of our undergraduate and graduate training. And often, one stared at him from a distance at important international and national professional meetings and gatherings of leaders of thought. It was indeed a delight to finally meet him some upwards of 15 years ago in Ile-Ife at the 60th birthday celebrations of Emeritus Professor Wale Akinshola, one of his very early mentees, and at which occasion he served as chairman. Professor Akinshola was my own teacher, and he called Professor Akinkugbe his teacher and mentor. I could, by virtue of professional patrimony, refer to Professor Akinkugbe as my own grand teacher. His contributions to medical education, university administration, and health services in Nigeria are so monumental and enduring that they continue to shape our institutional ideals and aspirations, even today, years after his service and demise. One of the things I had to do when preparing for this lecture was to go through the autobiography of Professor Akinkugbe, footprints and footnotes. And this gave me a first-hand knowledge and deeper understanding of the person of Professor Akinkugbe, his work, his legacy, and his life philosophy. He was almost larger than life, having served in so many national and international roles during his very long years of meritorious service. Having become a professor of medicine at 35 years, he went on to serve as Dean of Medicine in Ibadan, visiting Professor of Medicine at Harvard, Oxford, and Cape Town, and later Vice Chancellor at the University of Ilorin and ABU Zaria. He equally served as the Foundation Chair of JAMB and a subject matter expert to many national and international health and development partners, agencies, and groups, including the WHO and the Federal Ministry of Health. While this lecture, not in his memory, I make bold to say that he will have been the most qualified expert to speak on the subject matter of reimagining the Nigerian health system today, in the pedigree of the many other invited lectures and symposia he gave on the topic, because he was there from the beginning and he saw it all. My earliest contact with his published body of work was in 1996, while attending the update course of the National Postgraduate Medical College of Nigeria. I came across the report of the Expert Committee on Non-Communicable Diseases in Nigeria, a committee set up by the then Honorable Minister of Health, Professor Olikoye Ransom-Kuti, in 1988, to advise the country on the control of non-communicable diseases. The committee was chaired by Professor Akinkugbe, and their report centered on the prevalence of 5 major non-communicable diseases of interest: hypertension, diabetes, sickle cell disorders, coronary heart disease, and G6PD deficiency. This was published as a monograph for the use of all categories of medical practitioners in Nigeria. The committee eventually devised some means of integrating the control of the 5 NCDs into the country's primary healthcare system for wider applicability through another monograph edited by Dr. Olu Akinkugbe, and it was at that intersection that I crossed the path of this medical and literary icon. I've since gone ahead to familiarize myself with the corpus of his work, including his autobiography, and I dare to submit that he was a true master of his game. To borrow from the Bookcraft review of his autobiography, he was so aptly described. Professor Akinkugbe used his opportunities of service in various capacities in public life and in the corridors of power to address seminal and critical issues in health and higher education and influence them in a positive manner. He punctuates his rich harvest of experience with gripping anecdotes, telling his story with unusual clarity and candor, and there cannot be many personal accounts that reflect achievements and challenges in such refined and graceful style. The racy and engaging rendering of Akinkugbe's storytelling attests to his facility of language and a robust intellect that combines sustained scholarship with disarming modesty. Need anybody say more? It was only at the 50th anniversary of the West African College of Physicians Nigerian chapter in Ibadan last week that the memory of Professor Oladipo Akinkugbe was so honored by the words on display on our screen. And essentially, what was said was that when the West African College of Physicians held its foundation meeting in 1976, there was only one Nigerian in the room, the person of Professor Oladipo Akinkugbe. From that singular presence, thousands of physicians have been trained, examined, and certified across West Africa. And as we mark 50 years, we remember the shoulders on whom we stand. This was only last week in Ibadan. Once again, I congratulate the children, the grandchildren, the family, entire family and friends of Professor Akinkugbe for being the lucky heirs to such graceful legacy of service to country and mankind, and the university too for her foresight and wit in instituting this lecture series in perpetuity. May the soul of Professor Oladipo Akinkugbe continue to rest in peace, and may his memory continue to be a blessing to the living. Amen. Let us now venture into this business and our topic for discussion. Reimagining the Nigerian healthcare system, leadership, innovation, research and innovation for the future. Mr. Chairperson, the The topic I've been given this morning is a very apt and timely one in the annals of history of our dear nation. And I'm not unmindful of the diversity of the audience in this room. Permit me, therefore, not to make this entirely an academic conference presentation-like discussion with raw statistics, figures, and graphs only, but to employ a hybrid strategy interlacing serious academic engagements with periods of storytelling in order to fully and successfully engage every member of this audience for the entire duration of this lecture. Introduction. When we say the health system, what exactly do we mean? A health system is a complete network of organizations, institutions, resources, whose primary purpose is to promote, restore, or maintain health. It encompasses everything from doctors, hospitals, medical supply chains, to public health programs, health insurance, government policies, and the implementing actors. A well-functioning health system is built on specific core components to achieve equitable care. According to WHO, these core components consist of 6 interconnected building blocks that include service delivery, health workforce, health financing, health information systems, medical products and technologies, and leadership and governance that essentially provides the policy frameworks, the regulations, and oversight to ensure accountability and strategic management. Ultimately, the success of any health system is measured by 3 main objectives. Improving health. That is the main purpose of the health system, to improve health, that is enhancing the overall health and life expectancy of a population. Secondly, responsiveness. How is the system able to treat patients with dignity and provide services in a timely, respective manner? And thirdly, financial fairness, ensuring that no one is pushed into poverty due to medical costs without catastrophic expenditures. Those are the 3 main objectives of any functioning health system. In the Nigerian context, health is on the concurrent legislative list, and the local healthcare architecture is managed through a 3-tiered structure. The primary care, managed by the local government to provide basic first contact care for all citizens. Secondary care, managed by the state governments to provide some specialized referral services to general and specialist hospitals. And tertiary care, managed by the federal government, focusing on highly specialized treatment, advanced research, and medical training through teaching hospitals and federal medical centers. With regard to the core components and interconnecting building blocks of the health system, 2 are most germane to the delivery and efficient provision of health services. These are health leadership and governance and human resources for health. This is because these 2 comprise the human capital that make the health policies, take decisions, mobilize all the necessary resources in there to deliver care, translate the policy decisions into action, and convert resources to tangible health for the people. Health system governance refers to the process, structures, institutions that are in place to oversee and manage a country's health system. It manages the relationships between different actors and stakeholders involved in healthcare, including government agencies, healthcare providers, patients and their families, people and communities, civil society organizations, and private sector entities. It means ensuring strategic policy framework exists and are combined with effective oversight, coalition building, provision of appropriate regulation and incentives, attention to system design, and accountability. This requires efficient and equitable allocation of health resources, the presence of policies and regulations guiding healthcare delivery, and mechanisms for monitoring, evaluation, and reviewing the healthcare system performance. This will include officials with oversight functions at the executive and legislative arms of government and the health ministries, departments, and agencies at various levels. On the other hand, health workforce simply refers to the health workers of the various categories serving in different tiers of care, including community, primary, secondary, and tertiary, that provide the care and services that promote, maintain, and restore health and prevent diseases in the population. Let's go to the second part of this lecture by taking a broad overview today of the Nigerian health system. A quick broad overview of the Nigerian health system as obtained today. Within the background given, let us take a broad overview of the Nigerian healthcare system, citing specific examples of what obtains in some core components in 2026. Number one, citizens' health behavior. The first component we want to look at, citizens' health behavior. The Nigerian healthcare system today is at a critical juncture with significant challenges that require immediate attention and action. The system is marked by a fundamental lack of trust from the common man, woman, and child. The most despicable verdict against the health system that I often witness is the first-tier illness behavior of the average citizen. They often present at the patent medicines vendor or pharmacy shop at the first onset of symptoms, rather than at the primary healthcare center, the doctor's office, or the general hospital. There, at the PMV, they consult the front desk apprentice sales agent, most times a recent school leaver who is still studying to pass the O-level subjects. They present with complaints that range from simple cough, fever, and headache to features of chronic osteoarthritis, acute lung infections, and anemia, and asking the unskilled sales boy or girl for advice on the relevant medications and dosage regimens. Across the counter of the PMV or the pharmacy shop, Nigerians of all ages and social strata request to purchase such over-the-counter drugs as paracetamol and cough syrups to prescriptive third-generation cephalosporins, antibiotics, antihypertensives, blood sugar-lowering drugs, and sedatives that essentially require the doctor's prescription and the pharmacist's advice on possible adverse drug interactions. They bring patients of all ages, from infants and toddlers to adolescents, pregnant women, and even the aged and the physically challenged. As I stand there at those drug counters, I cringe at the complaints and the requests that are coming from the patients and the caregivers, and the responses coming from the sales personnel. Oftentimes, I'll be tempted to shout, "Please stop this. I'm a doctor and I think this is wrong and most unsafe for everybody." But when I also remember the state of the formal health system, the red tapeism associated with accessing care at the health center and the general hospital, and the attitude of the staff, if and when available, and the waiting time for the patients, I close my eyes and just concentrate on my own mission to the pharmacy shop, and I get out. Why is this introductory story so important? It speaks to two things about the Nigerian health system today. First, the distrust of the citizens for the system to quickly meet their needs in an efficient manner when they need it most. And secondly, the weakness of the regulatory agencies of government that tolerate a system whereby virtually anything and everything can be purchased across the counter without consequences. In this state of anomy, the entire health system, and indeed the entire country, is a loser. Let's look at the second broad overview content: shortage of skilled healthcare workers and the crisis of supply. One of the most pressing challenges of the health system today is the severe shortage of skilled healthcare workers, with the country currently having a density, a health worker density of 1.83 skilled health workers per 1,000 population, which falls short of the WHO's recommendation of 4.45 skilled workers per 1,000 population. Nigeria currently has a doctor-to-patient ratio of approximately 1 to 5,000, which is more than 8 times worse than the global standard of 1 to 600, with a population expected to reach 263 million by 2030, and a growing trend of medical professionals leaving the country in droves. This problem is poised to worsen unless addressed fundamentally. The overwhelming workload is increasingly leading to burnout and mass exodus of health professionals, with an estimated 20,000 doctors having left the country in the last decade alone. At the lower level, where the staff emigration is relatively low, and if you look at these skilled health worker and the crisis of applied graph that is here, you see that in the whole of sub-Saharan Africa, I guess it's perhaps only Egypt that is able to meet close to the 4.45 skilled health worker density recommended by the WHO. South Africa, about the middle there, Nigeria coming third, but a very distant third and a very poor margin as that, 1.38, compared with 4.45, as was recommended. At the lower level, where staff immigration is relatively low, even the primary healthcare centers are not adequately staffed in terms of numbers, qualifications, and skill mix due to anomalies in health leadership and governance at the state level and the local government levels. Often, the sequelae of various cash and carry and wrongfully enacted health legislations and policies at those levels. A situation whereby a registered nurse midwife reports to and works under the superintendence of a community health officer in a primary health care center with a workload and her work description prescribed and regulated by the CHO is unacceptable and is a morale killer. I don't know how many of us have visited health centers of late where nurses used to be in charge, taking deliveries, manning the antenatal delivery, immunization, and everywhere. They've been so relegated to the maternity unit, and they will leave only one midwife there who takes instruction from a CHO, a glorified CHO of old, but who has stepped up. And we think this system will improve that way. No. It will not. These are cash and carry legislations that people have gone to procure, and these are the issues that are destroying the health system of this country today. Worse still, the career of this midwife terminates at a lower level than that of the CHO, who can now aspire to a level 17 officer before retirement, whereas the nurse midwife will have to retire at level 16 or thereabout. Complete miscarriage of justice. The relationship between health worker staffing levels and the primary health care facility functionality demonstrates a strong positive correlation. This underscores the centrality of human resources to service delivery capacity. Based on currently available data, only 21% of Nigerian primary health care center facilities meet the criteria for functional level 2 status. That is, capable of providing 24/7 services that include delivery services, antenatal care, outpatient care, immunization, adult outpatient, and with adequate staffing, power, and infrastructure. PHC facilities with fewer than 2 skilled staff report functionality rates of below 12%, meaning that fewer than 1 in 8 facilities can provide basic primary health care facilities, including outpatient consultations, immunizations, and maternity services. Those with 6 or more skilled staff approach the 50% functional threshold, while those with 10 or more staff achieve functionality rates of 80% and thereabout. This is where every health center should be. Functional level 2. Open 24 hours, deliver the mix of services required, power, water, other infrastructure, but only 21% of primary healthcare centers in this country meet those criteria today. In fact, a lot of them are here with 2 or fewer than 2 healthcare workers. Unfortunately, most of the primary healthcare centers, especially the rural ones, are often left poorly manned all year round, as many of the officers live in the metropolis and only make arrangements to cover their beats for certain periods of the month, while they spend the bulk of their time at home in the state capitals, attending to other businesses and family interests. Why should anybody then blame the average Nigerian patient who first presents at the patent medicine vendor store at the first symptom of illness? Whereas evidence abounds today that at least 1 of every 5 extraordinary talents in any organizations overseas is a Nigerian, and health professionals form a large chunk of these people. While the syndrome is not novel at all, as there is evidence that as far back as 1988, the then military president Ibrahim Babangida did set up a presidential committee on brain drain under the leadership of Professor Akingugbe, whose committee reported that about 10,094 professionals had at that time been lost from our tertiary institutions alone. What is, however, of concern today is the meteoric spike the syndrome has taken in recent times. As individuals continue to flee the country in droves, so also are corporate entities, multinationals, and foreign direct investments. The exodus of multinationals such as GSK, Sanofi, P&G, Unilever, Bolt Food, Jumia, PZ Cousins, to mention a few, coupled with the looming transition away from donor-funded mechanisms, has created a crisis of supply. Their departure created market gaps, worsened shortages, and drove up prices. Reports indicate that the cost of some medicines have surged by more than 1,100%, placing essential treatment out of the reach of many individuals and households. According to the Nigeria Employers Consultative Association, Nigeria lost 15 multinationals between 2021 and 2023, leading to the loss of over 20,000 jobs. Many hospitals, production and research centers in Nigeria today are now without specialists and consultants, while the list of Nigerian specialists who left for the diaspora and are doing great exploits is long and endless. Thousands of them are providing stability for the health system of their newly adopted countries. The harsh reality is that many teaching hospital wards, clinics, and academic departments, from LUTH to LASUTH to UCH to AUTHC, and possibly here in UNIMED, are shutting down due to shortage of nurses and doctors on account of their massive relocation abroad. And many more will still shut down unless something is done and urgently to arrest this malady. The potential effect of this danger to our already feeble health system is better imagined than expressed. But the managers of our health system had hitherto treated this crisis with levity, as one past labor minister was publicly quoted to have said that the mass exodus of health professionals was good for the country and a source of foreign exchange earnings as an incentive to continue to train more professionals for the global market. Yet, within this crisis lies profound opportunity to transform from dependence to one of sovereignty and self-sufficiency, if only we can seize the opportunity. The current health minister has, however, embraced the crisis of the severe shortage of health workers, acknowledging that there are only about 55,000 licensed doctors left in this country to serve over 240 million people. He observed that in the last 5 years only, 16,000 doctors have left the country, and equally expressed concern about the mass exodus of other healthcare professionals seeking better opportunities abroad and leaving Nigeria with bare minimum of professionals to manage our system. Retaining and empowering skilled healthcare staff in our labor force is the magic wand needed to change the Nigerian narrative to an enviable one, and to truly mark the beginning of the Nigerian health sector reform. Challenges of healthcare that are unique to women. Women's healthcare in Nigeria also faces its own set of unique challenges that require urgent attention. As the bedrock of society, women often find themselves at the forefront of healthcare needs, yet their specific concerns are often overlooked or dismissed. Conditions such as fibroids, endometriosis, and breast cancer frequently go undiagnosed or are misdiagnosed due to lack of understanding and skills and lack of specialized care. The barriers women face in accessing health care, including the need for permission from family members in some parts of the country to even seek care, and the financial constraints that they often face, further exacerbate these issues. The high rate of maternal and infant mortality in Nigeria are a testament to the dire state of women's health care. Nigeria currently holds the world record for the highest absolute maternal mortality burden. The highest absolute, not the highest maternal mortality ratio, but the highest absolute maternal mortality burden, that is the number of deaths of any country. We're only a country of 240 million people. China and India are 1.5 billion each. And many more women die in Nigeria than in China and in India each, from childbirth-related, pregnancy and childbirth-related issues. There is a problem, ladies and gentlemen, with 75,000 to 80,000 annual maternal deaths, constituting 27 to 29% of the global total of maternal mortality, and about 1 in 100 pregnant women dying during pregnancy and childbirth in this country. This staggering statistic reflects the systemic failures in addressing the unique needs of women and the failure of prioritization of maternal and child health. The prevalence of gender-based violence, including sexual violence and domestic abuse, further compound the challenges often faced by women in Nigeria. These social determinants of health have a profound impact on the overall well-being of women and their access to quality health care. Current HIV burden and the national response. Nigeria remains one of the countries most affected by HIV globally, with about 2 million people living with the virus and an adult prevalence of around 1.3% among people aged 15 to 49 years, crediting the country with about the 4th highest number of people living with HIV worldwide. You can see the statistics there. Beneath these averages lie deep inequities. Prevalence is significantly higher in several South-South and North-Central states and lower elsewhere. Women and girls bear a disproportionate burden of our HIV burden, accounting for 65% of adults living with HIV due to gender and power imbalances, economic vulnerability, gender-based violence. Over the past 2 decades, foreign partners have supported much of Nigeria's HIV progress. Between 2021 and 2025, Nigeria received more than $4.6 billion in international health grants from the Global Fund and USAID. And lawmakers noted that PEPFAR contributed an additional $6 billion over the same period. This external funding has been vital, but recent events show it is no longer sufficient or reliable as the basis for a sustainable HIV response. In early 2025, United States announced a temporary pause in foreign aid that affected several programs in Nigeria. For the HIV and AIDS control agenda, community workers and key population-led services were first hit and hardest to. More than 95% of PEPFAR-funded community workers received a stop work order, and over 80 one-stop shops faced similar disruptions. This is concerning because community-led organizations are essential for reaching the most at risk of HIV infection in any community. In 8 countries, including Nigeria, 89% of funding for community-led HIV organizations comes from bilateral donors, 10.9% from multilateral donors, and less than 0.1% from domestic sources. This reflects the real consequences of a system that remains dependent on external funding and vulnerable to shifts in foreign policy decisions. These disruptions came at a time when the world is closer than ever to ending AIDS as a public health threat, yet still off track to meet the 2030 global agenda. Domestic HIV funding globally now accounts for only 52% of total spending, and UNAIDS recommend that 2/3 should come from domestic sources by 2030. In the light of this, the World AIDS Day 2025 theme of overcoming disruption, transforming the AIDS response was crucial for Nigeria. The country stands at crossroads between maintaining a donor-dependent architecture that remains vulnerable to external decisions and building a stable, domestically funded and community-led response capable of withstanding political and economic shocks in the coming years. And the last of them that we're going to look at the broad overview of the health system also is the Nigerian emergency response system, our emergency response system. Nigeria also has a poorly developed emergency response system, characterized by inadequate ambulance networks and poorly trained and equipped first responders. Most well-equipped ambulances are privately owned and provide care only to individuals who can afford to pay the price tag for the services, maybe the exception of Lagos State and a few Southwest states for that matter. A disconcerting aspect of our national life is the fact that the average educated Nigerian does not have the basic first aid knowledge and cardiopulmonary resuscitation skills, unlike what obtains in many other climes. I know back in our college in Ife, College of Health Sciences, in the last 2 years, in my department, we have a course called Introduction to SCHO1, Man and His Health. I think that's the name of the course. And so many students of the university come to subscribe in their thousands, sometimes 5,000, 6,000, because special electives they're part of the compulsory things you need to do in Ife. What we've tried to do towards solving the problem of people not having CPR skills is to take through all the students who register for that course through a short course on CPR, and where it is demonstrated and they themselves are able to practice for a little fee, and then they get certified. And we hope that will get into a multiplier effect. And if that is not happening, I pray it is happening here already at UNIM, but if it's not, I think we should start to train all our students and every member of staff on CPR, but that is the way to go. Consequently, when attempting to save lives, many civic volunteers, who are usually the first responders, cause more harm to the patient than good, and often constitute an obstacle for the first responders to reach the casualties. You can imagine these first responders. Look at what is surrounding them. To even get to the site of the emergency becomes a problem. Nigerians will have thrown the entire place. They'll be pulling somebody who already has a spinal cord injury. I think this is one big area that we need to do something very urgently about in this country. Health system resilience and health security preparedness. Lastly, the application of Crooks et al.'s resilience framework to Nigeria's health system reveals significant weakness across all the 5 resilience dimensions. This is the Crooks et al.'s framework for health resilience. And the components are awareness, diversity, self-regulation, integration, and adaptability. If you look at that table, it presents the resilience assessment scoring for each dimension based on available evidence in the country today. The resilience assessment reveals that Nigeria's health system scores very weak across 4 of the 5 resilience dimensions and only partially fair on the 5th one. The diversity dimension is critically weak due to the extreme geographic concentration of health workers in urban areas and the limited range of service delivery platforms with adequate staffing. So, diversity, 78% only in the urban areas. resilience, sorry. The diversity dimension is critically weak due to, self-regulation is weak due to the loss of experienced supervisors and quality assurance officers due to the ensuing brain drain that continues very, very unabated. Integration is weak due to disconnect between training and service delivery and the fragmentation of governance across federal, state, and local levels. Adaptability is weak due to erosion of human capacity for innovation and the limited evidence of transformative policy responses to the workforce crisis. But that is our scorecard in 2026. Weak health system, resilience, and workforce attrition have major implications for Nigeria's health security preparedness. Shortages of epidemiologists, laboratory scientists, and public health specialists undermine the country's ability to meet international health regulations, requirements, and respond effectively to disease outbreak. As we saw during the COVID-19 pandemic, it demonstrated the importance of a strong workforce for surveillance, for testing, for treatment, and for vaccination efforts. In addition, the concentration of health workers in urban areas limits equitable access to care and hinders progress towards universal health coverage. Workforce losses reduce institutional memory, weaken supervision and quality assurance systems, and limit the health system's capacity to adapt to emerging challenges. So, what are the Nigerian health status indicators and health-related indicators in 2026 today? What do our health indicators? We just had a broad overview of what our health system looks like. Now, what are the health status indicators and the health-related indicators in 2026? And in many quarters and circles, what is said now today is that 2026 is the new 2016. 2026 is the new 2016. Must be joking. Rather than merely quoting some cross-sectional Nigerian health system status statistics for 2026, which may actually sound rhetorical to a lot of people, it may be more expedient comparing the Nigerian health situation today with what obtained 10 years ago for proper context and situational perspectives. That way, we can at least examine some metrics of growth and development in relative terms. Today, Nigerians are riding on the global 2026 is the 2016 wave, posting throwbacks and then versus now comparisons that ask what has really changed in 10 years. In a decade, there are noticeable transformations across several sectors of the Nigerian economy. The Nigerian music industry and film industry, for instance, now reach the global audience through platforms such as Netflix and Spotify. The tech ecosystem has expanded rapidly with fintech and growing engagements with artificial intelligence, reshaping how Nigerians work, learn, and build solutions. But can the same be said of the country's health system? Let's take a look at a few critical indicators. Health funding. With regards to health funding, the relationship between 2016 and 2026 can be aptly summed up as less neglect, more ambition, but then repetition. And I will explain that. In 2016, Nigeria's health system was under visible strain, shaped by fiscal tightening and deep structural weaknesses that limited what budgets could translate into at the health facility level. In 2016, out-of-pocket expenses accounted for 75.2% of our health expenditure. In 2026, it is 76.1. Oh, okay, it's not there. I thought, so 75.2 in 2016, 76.1 out-of-pocket expenditure in 2026. A signal that financial protection has neither taken root nor changed the lot of the people. In 2026, the talk of transformation is louder, but the lived reality of many Nigerians is familiar. care is still often accessed when people can pay, not when they need it. Funding frameworks may be more elaborate on paper, but health still sits very low among public priorities, and households remain the primary funders of healthcare. That reality reinforces a damaging message that access depends more on personal means than public protection. And when coverage is measured, progress still looks very modest. Nigeria's Universal Health Coverage Service Index was 44 in 2016, and is about 47 in 2026, barely shifting over the last decade, and far more from what Nigerians need from a primary healthcare-led system. This index, measured on a scale of 0 to 100 by the WHO, tracks essential health services across reproductive, maternal, and child health, infectious and non-communicable diseases, and service capacity, with 100 scoring highest and 0 being the least. The current score of 47 indicates significant ongoing gaps in access to quality essential healthcare services without financial hardship. In 2016, the federal government's total budget stood at 6.8 trillion, with about 257 billion, that is 4.2%, budgeted for health. The allocation was heavily inclined towards recurrent spending, limiting room for infrastructure, system strengthening, and long-term investment. Health funding was, however, far below the 15% target set by the Abuja Declaration. A decade later, the Naira figures are larger, but the proportions look stubbornly similar. In 2026, the government budgeted 2.48 trillion for health, and that is still 4.2% of the proposed 58 trillion federal budget of this year. The budget framework promises consolidation and resilience alongside stronger primary health care, expanded access, and faster progress towards universal health coverage. But nothing has changed. I'm not sure whether we expect any change when there is no change in budgeting proportion. The pattern of ambitious language, modest allocation, and a widening credibility gap between policy intent and financial commitment still persists today and accounts for my summary of neglect, more ambition, but mere repetition. The Abuja Declaration of 15% of 2015 says that the country must spend 42,000 annually on every citizen and 3,500 per month on every citizen. Today, we still spend 10,000 annually and 845 naira on every citizen. Even despite the National Assembly's intention to shoot this up to 15%, the gap is still there at 4%. This gap is not just a statistic, it's the difference between access to care and neglect for millions of Nigerians. Maternal and child health. Nigeria's maternal and child health indicators painted a grim picture in 2016. National estimates put the maternal mortality ratio then at 576 maternal deaths per 100,000 live births. Skilled attendance at birth was 38%, meaning 3 in 5 births happened without a skilled birth attendant. By 2026, progress is only incremental rather than transformative. By the latest available estimates, Nigeria's maternal mortality ratio today is about 512 per 100,000 live births, still a far cry from the SDG target 5 of 70. Skilled attendance improved from 38 to 46%, but that still leaves millions of women exposed to preventable risks. The point is not that nothing has changed. It is that change has not been sufficiently transformative to match the scale of avoidable deaths. In 2016, routine immunization coverage was already a warning light. DPT coverage stood at 38%, DPT 3, and by 2026, it is 53%. That's an upward movement, but not the kind that will build herd immunity, prevent outbreaks, and reassures parents that primary health care can reliably deliver essential care to their children. Health policy. In 2016, Nigeria approved the revised national health policy, framing health as a driver of socioeconomic development and aligning national goals with the Sustainable Development Goals. And that same year, the Nigerian supply chain policy for pharmaceuticals and other healthcare products was adopted to address fragmentation in the procurement and distribution of essential medicines and health commodities. A decade on today, many of those ambitions only remain partially realized. In 2026, the Nigerian healthcare system operates what we now call the National Health Sector Renewal Investment Initiative. And I'm sure many of us health workers in this room will be familiar, with our new policy for health that was unveiled in December 2023, following the adoption by the National Council on Health. This strategy focuses on revamping primary health care centers, the National Health Fellows Program, and expanding health insurance coverage to the most vulnerable of our citizens. It is positioned as a flagship agenda to accelerate universal health coverage, strengthen primary health care, improve service delivery across states using the sector-wide approach. While the policy has recorded some significant gains in 3 years, including the renovation of thousands of health centers nationwide, substantial enrollment of Nigerians by the National Health Insurance Agency into the basic healthcare provision for facilities, and training of thousands of primary healthcare workers, the policy still faces persistent hurdles in 2026, largely stemming from severe human resources shortage occasioned by the brain drain, inadequate infrastructure that limits the functionality of primary healthcare centers, inadequate funding, and the persistent poor health insurance penetration, resulting in heavy out-of-pocket expenditure when patients visit health facilities. These challenges are compounded by fragmented service delivery and climate-induced disease outbreaks across the country. This National Health Sector Renewal Initiative also continues to build on earlier reforms rather than replacing them, which reveals both progress and stagnation. We keep diagnosing the same gaps, but the implementation remains uneven, especially in the different parts of the country. Policy on antimicrobial resistance. Very serious issue confronting our health system today. Nigeria's response to antimicrobial resistance captures the tension between leadership and delivery. In June 2016, Nigeria developed a multi-sector national action plan on antimicrobial resistance, 2017 to 2022, designed to strengthen surveillance, stewardship, infection prevention and control, and governance across human, animal, and environmental health. The plan achieved only 44% implementation at the end point, and the second National Action Plan on Antimicrobial Resistance 2024 to 2028 was developed, signaling the urgency, but real test is in sustained implementation, funding, and enforcement beyond the documents themselves. In 2026, this year, Nigeria will host the 5th Global High-Level Ministerial Conference on Antimicrobial Resistance. The symbolism is powerful, but the question is not whether Nigeria can speak convincingly about antimicrobial resistance, but whether health facilities, pharmacies, and communities will experience tighter stewardship, stronger regulation, and better diagnostics where it matters most. Today, high purchase costs compounded by economic pressures prompt many Nigerians, especially those in the rural areas and the fringe of society, to seek cheaper alternatives to drugs and medical products from informal agents or unlicensed vendors, as I already discussed in my introduction. In addition to these informal outlets, open drug markets play a major role in medicine distribution, supplying both licensed retailers and end users directly. These markets bypass formal regulatory channels and significantly increase the risk of exposure to substandard and falsified medical products, thereby increasing the risk of antimicrobial resistance. The job of NAFDAC and those of the health professional regulatory agencies are yet largely uncompleted. The health workforce, the jugular, itself. In 2016, federal government spoke repeatedly about industrial harmony. Yet, resident doctors still down tools. In May 2016, the National Association of Resident Doctors declared a 5-day nationwide strike, citing upward unpaid salaries and arrears and other unresolved issues, with patients in public hospitals forced to rely on the fewer consultants available. By June 2016, NAT declared further, announcing an indefinite shutdown after months of engagement, a warning strike, and ultimatums that it did not deliver on remuneration and welfare commitment. Fast forward to 2026, January, and the same story played out, only louder this time, longer and more system-wide. The Nigerian Association of Resident Doctors commenced a nationwide strike, dubbed TI20, no implementation, no going back, on January 12, 2026. The joint health sector unions that had all the other health professionals combined commenced an indefinite nationwide strike on November 14, 2025, and by mid-January 2026, it was still ongoing, with the union alleging major service and revenue disruptions across 73 health institutions in this country. The strike centered on salary arrears, unfulfilled agreements, allowance adjustments, and improved hospital working conditions. The Federal Ministry of Health successfully resolved the JOESO strike in February 2026 by withdrawing the No Work, No Pay directive, approving the January salaries, and committing to budgetary provision for the Cohen's adjustment in 2026 Appropriation Act. However, by June, only last month, fresh threat of industrial action were issued to the federal government by JOESO over the government's failure to implement the long-awaited adjustment of the Cohen's salary structure. Various local branches of the Association of Resident Doctors across the country are still currently on strike over issues of unfulfilled agreements and poor welfare, even in the face of the health worker immigration crisis that continues to bite harder, reinforcing what I call a strike immigration loop. Nigeria's national policy on health workforce migration flagged outwards movement using letters of good standing, and it shows that this immigration peaked at over 3,000 doctors in 2022 alone. Peer-reviewed evidence links the strike migration loop to the same underlying drivers such as pay, working conditions, career progression, and system governance. The hard comparison 10 years later is that when strikes repeatedly interrupt care and migration steadily drains experienced staff, the system pays twice, first in service disruption today, and then in reduced capacity tomorrow. The question for 2026 is whether Nigeria will keep treating health workers' welfare, pay equity, and workplace conditions as episodic labor disputes, or finally, as a core health system reform that directly determine access, quality, and sustainable growth and development. As nostalgia follows our timelines, and 2016 replaces itself, Nigeria faces a far less entertaining question of not whether 2026 feels like 2016, but whether we are comfortable letting history repeat itself. Trends come and go, but systems endure. The real choice is whether we accept another decade of deja vu or decide now that the failures of 2016 and 2026 will not be the ones we are explaining in 2036. If 2026 mirrors 2016, it is because we keep funding promises, not funding concrete healthcare interventions. Nigeria must finance primary healthcare, protect households, implement reforms, and fix the welfare of healthcare workers today, not in 2036. And lastly, my own roadmap to reform the Nigerian healthcare system, talking about leadership, research, innovation for the future. While the current Nigerian administration has been more ambitious and intentional at reforming the health sector, and the planned transformation has equally been louder, it still has a It still has to take a number of unprecedented steps if the healthcare system must be preserved from imminent collapse due to the ongoing health workforce mass exodus across the country and related funding issues. Some steps must be sufficiently bold and taken outside of the health system, although all will snowball to positively impact the health system on the long run. First thing, we must prioritize funding and financing. This country must, as of today now, prioritize healthcare financing and funding. Adequate and sustainable funding is the foundation for transformative change in the healthcare sector. Nigeria must prioritize healthcare financing with a focus on increasing public funding and expanding risk protection mechanisms to ensure universal health access to care, regardless of whether an individual is able to pay or not. Specifically, we must allocate larger percentage of the national budget to health care, with a target of at least 2% of the consolidated revenue fund as stipulated in the National Health Act of 2014. Rejig a functional and equitable health insurance system, preferably the community-based health insurance scheme, that would drastically reduce the burden of out-of-pocket expenses and provide financial risk protection for all Nigerians. The blueprints are available. In 2016, when I served as research advisor to the Shell Petroleum Development Company, we had a model community-based health insurance scheme for the Obiakpo local government of River State. And community-based health insurance access was 95% because a private sector led the initiative. All the blueprints to deploy community-based insurance are there. It's all about who will fund it. If the budget is still 4.2%, people will continue to do out-of-pocket expenditure. We have not put enough money in the health sector if we really want to help the system. And so I said, we must rejig a functional and equitable health insurance system, preferably the community-based health insurance, to drastically reduce the burden of out-of-pocket expenditure and provide financial risk protection for all Nigerians, and explore innovative financing strategies, such as private sector endowments, earmarked taxes on goods and services of interest to supplement government funding and ensure the sustainability of the healthcare system. We must strive to intentionally increase the total national spending on health from 4.2% to the total of the federal budget to the 15% African Union benchmark agreed upon at the Abuja Declaration of 2001, if the country must overcome several of the aforementioned challenges and achieve universal health coverage for all. This is a call on the government, good-spirited individuals, corporate organizations to organize and set up counterpart interventions and trust funds, similar to TED Fund, to provide supplementary support for the health system and the institutions. Truth be said, government might not be able to adequately fund health and education interventions alone without the support of the private individuals, corporations, foundations, and alumni. I'm a living witness of the power of the alumni in the lives of global institutions, including our own College of Health Sciences at the OAU. It is high time the bull was taken by the horn to reduce the great citadels of learning that made the Oladipo Akinkugbe of this world and the rest of us proud citizens of the world. Corporate organizations should look beyond sponsoring student jamborees that they refer to as their corporate social responsibilities and start to truly invest in sustainable interventions in our health and educational interventions. Human resources and capacity building. Human capital is the most critical resource for national development and is intricately linked with healthcare financing. An investment in human capital will undoubtedly yield a simultaneous increase in innovation, social well-being, and productivity. The salary disparity between Nigerian health professionals and their counterparts in other climes must, as a matter of urgent national importance, be addressed. as this has become a veritable recipe for brain drain. In August 2023, the chair of the Committee of CMDs of Federal Teaching Hospitals, Mbasi, while speaking before the ad hoc committee of the House on employment racketeering in federal agencies, submitted that even African countries are now poaching Nigerian medical specialists and other health professionals by offering them salaries that range from $3,000 to $5,000 monthly, something that is now 3 to 5 times more than what they are paid locally. Government at all levels must critically review their health reward systems for health professionals and use the strategy for collective bargaining to arrive at a living and realistic wage that can give health professionals the basic comforts of family living and safety, while they will in turn concentrate on the health of Nigerians. To continue to treat health workers as civil servants and say we can't pay them out of context with the other civil servants. As I speak, 2 of my own professor colleagues in Ife, I know are in sub-Saharan West African countries in West Africa, preferring to have their trade there, earning, even if it's only $5,000 a month, they know what to do with it at the end of the month. So we are borrowing the government some good advice. Adequate funding of our health and educational institutions will ensure adequate remuneration for both Nigerian health professionals and academics alike, and will likely prevent incessant strikes and industrial disharmony in the system. But I must say, and I must credit this present administration, that they introduced in 2024 the National Policy on Health Workforce Migration that is reportedly trying to tackle many of the critical problems. And I want to just quote what the Health Minister said. He said, this policy aims to stem the exodus of health professionals, and it is more than just a response to the ongoing exodus of health professionals. It's a comprehensive strategy to manage, harness, and reverse health worker migration, and envisions a striking force that is well supported, adequately rewarded, optimally utilized to meet healthcare needs of Nigerians. And he further remarked that the policy will create an environment that encourages professional development and stability and seeks to retain the best talent within Nigeria. The message cannot be more apt at this time and seems to strike all the right chords that makes all the necessary optics. But what exactly are the details of the policy? The policy is expected to introduce targeted incentives for healthcare workers, especially those in the rural areas. It's supposed to include special programs, improved medical supplies, mortgage for facilities, tax breaks, and regular salary reviews. The policy aims to enhance training by expanding the capacity of medical schools, and that's why many of our institutions have had their quotas doubled, and training institutions to produce more healthcare professionals, including doctors, nurses, and allied health workers, fostering international collaboration and funding postgraduate education. It will support one facility per ward initiative, where at least in every political ward, a facility will be taken, a PhD will be taken to the functional level 2, as I described earlier, and include measures for worker safety and well-being, with ongoing monitoring to track migration patterns and inform adjustments. The policy emphasis is on digital health infrastructure, including electronic medical records, telehealth, and a comprehensive health workforce registry that represent a major milestone towards a more efficient and data-driven health system. Also, the policy is expected to champion reciprocal agreements with other nations to ensure that exchange of health workers benefits Nigeria. These bilateral and multilateral agreements are designed to protect national interests while respecting the rights and aspirations of healthcare professionals. It calls on recipient nations to implement one-on-one match training world health worker to replace every publicly trained Nigerian health worker that leaves, and many, many other parts of what the policy says. Although the policy has several strengths, such as comprehensive approach and focus on improving conditions in rural areas, it also has notable pitfalls, even on arrival. Comparing the Nigerians' approach to other countries facing similar challenges reveal both similarities and differences. Many nations, including those of the Caribbean and Sub-Saharan Africa, use incentive programs to retain healthcare workforce in underserved regions. However, Nigeria's policy is less detailed in terms of economic incentives compared with other countries that offer substantial salary increases and benefits. Absence of specificity regarding economic incentives and improvement in salaries will undermine the effectiveness of this policy on day one. Although the policy incorporates systems for integrating returning Nigerian diaspora healthcare workers into the system, poor health worker remuneration and ravaging insecurity in the country are major elephants that continue to create the push factors that cause Nigerian health workers to want to flee the country and also keep the Nigerian diaspora health workers away from returning. Countries such as Philippines have more established frameworks for leveraging diaspora expertise that Nigeria can learn from. As Nigeria continues to refine its approach, learning from different models will enhance the effectiveness of this policy better and address the challenges faced by the healthcare system today. Although 2025 retirement age extension policy provides temporary relief, it cannot address workforce shortages unless accompanied by broader retention and recruitment strategies. Reform the primary health care system in the true letter and spirit of primary health care. There are ongoing reforms to revamp the country's primary health care system. PHC centers are being refurbished by the federal government, state, and LGAs under various schemes and incentives, no matter how incremental in scope and tokenistic in coverage. This is commendable, but has to be done at scale countrywide, beyond the politics and optics of it, if it must truly transform the healthcare delivery system of our country. Besides, there is more to care seeking and caregiving than the physical infrastructure upgrade of facilities. This must be accompanied by corresponding complement of skilled, compassionate, motivated, and accountable health workers of the right number and mix, offering the primary healthcare service mix on a 24-hour basis, functional and when-stock pharmacy units, laboratory backup for basic investigations, necessary amenities, stable power and water at the least, and a functional referral system. Given that the majority of Nigeria's 31,800 PHC facilities operate with fewer than 4 skilled staff, the aggregate functionality deficit represents a critical barrier to universal health coverage. Available data suggests that a minimum threshold of 6 skilled staff per facility is required to achieve basic functionality, implying a need for approximately 130,000 additional primary health care workers to be recruited to bring all facilities to minimum operational standards across the country. Above all, there must be a functional community-based health insurance. We cannot overemphasize this in the various communities if we must replace the pervasive out-of-pocket spending for health and its accompanying catastrophic health expenditure among citizens. It's only when the citizens are able to access such high-quality care and service mix close to where they live and work that customer confidence will be restored in the system, and Nigerians will once again prioritize primary healthcare facilities as the first point of care at the onset of illness, over and above the current practice of patronizing patent medicine vendors and TBAs. This is actually the social contract and obligation that government leaders at all levels have with the citizens, and it is doable if the elected leaders will choose to be accountable. We must expand access to specialized services and leverage the expertise of Nigerians in diaspora. How do I mean? The Premier University of Ibadan had an international reputation as a leading center of excellence in tropical medicine. And news had it that the Saudi royal family used to frequent UCH for medical treatment in the 60s and the 70s, while Professor Oladipo Akinkugbe and his peers of that era took charge. That would not have been the case if the center did not boast of the requisite staff, infrastructure, supplies, and utilities of that era. Many of the experts who performed the feats then trained abroad and returned from their overseas studies to develop their centers at home. Many of us have read about and experienced, as the VC said this morning, Professor Akinkugbe and his renal and hypertension clinics and units in Ibadan, Professor Oladipo Akinkugbe and his neurosurgery exploits in Ibadan, Professor T.I. Grillo and his anatomy laboratories and studies in Ife, and Professor Akinkugbe and his pediatric surgery work in Ife, just to mention a few. We equally today have many public centers that are doing great exploits: open heart surgeries, brain and spine surgeries, cardiac bypass surgeries, renal transplants, etc. But most of them are poorly funded, poorly equipped, and poorly staffed by today's standards. Stable power, as sacrosanct as it is to the delivery of safe care, is often lacking. Most of our teaching hospitals today, and I may bold to say this because I know a number in the Southwest, do not have a functioning MRI machine, and often send patients to the few private facilities that offer the services, even in between complex surgeries. The patient is operated, brain surgery. I saw one 3 months ago. He came out of theater. 4 hours after, he was being sent from UCH to Adioyo on Ring Road to go and have an MRI, to come back, because UCH does not have a functioning MRI. Neither does Ife or many of the other, highbrow teaching hospitals. Those are not the hospitals the Akinkugbe managed. So they send patients to few private facilities offering the service, even in between complex surgeries, with the attendant complications of transporting critically ill patients. Such deprived public centers cannot attract any of our diaspora talents to come back and work in them, because they will simply be lost and unable to understand how any system will work in such great lack and depravity. We must also expand access to highly specialized care services, even if only a few of them are publicly available, and Nigerians have to crowdfund to access services when urgently needed. This will be cheaper than our health tourism, which is currently the exclusive reserve of the rich and privileged. Only very recently, and I say this with a lot of sadness, because the case I'm about to cite was like a son to me. He was my own son's best friend. And I'm beginning to have to manage my son for some psychological issues now because of the death of this boy. Only very recently, a 20-year-old final year student of one of our universities was diagnosed with a benign brain tumor, deeply seated in the thalamus. Our neurosurgery colleagues in the public facilities, and I mean public facilities because I went to Lagos, I went to Ibadan, and I went to Ife. 3 of our best teaching hospitals in the Southwest, they were reluctant to attempt to open open brain surgery, even if only to take biopsy for histological diagnosis, because of the risks involved with reaching the location of the tumor in the absence of much needed specialized operating equipment and support services. They were just being careful. They were ready to work. But what they needed to work with, they said that was a deep-seated tumor, and that to get in there was going to be difficult, and they would be causing a lot of collateral damage. Everybody advised that the patient will most benefit from radio surgery, or what is called stereotactic surgery, not the conventional radiotherapy, where the patient will not need to be opened up, but can have the tumor just melted away, non-invasively, after a few sessions of intensely focused 3D map radiation beams. Alas, there was no single center, public or private, offering such service in Nigeria. Out of desperation and worsening symptoms, the boy was subjected to open brain surgery by a willing surgeon after much persuasion and begging for both tissue biopsy and possible debulking of this tumor. Unfortunately, the boy died from post-surgical complications that were not unconnected with the shortage of specialized operating equipment and support systems, notably power supply. For most of the time he was in usage, there was no power. Our government at all levels must wake up from this slumber and learn with vigor how to adequately recognize and reward all Nigerian talents, home and abroad, who are poking the world with their ingenious touches and excellence, even as we strive to reenact the good old days when Nigeria was a pride to the world. We must of necessity become averse to being comfortable with poor outcomes and preventable loss of lives of the young and the old due to poor investment in the health system. The few private facilities that are providing highly specialized service in the country today are outrightly unaffordable by the average Nigerian, as their services sometimes cost tens of millions of naira. We must prioritize implementation research, and this is what affects you and me directly. We must henceforth prioritize implementation research for evidence. The toolkit of evidence-based interventions continues to grow globally, and with it, the knowledge-practice gap. Some interventions are not implemented at all, or implemented poorly, with poor fidelity to the design that was shown to be effective due to constraints of context and geography. Other interventions only benefit high-income countries or the most affluent ones and increase inequity, while others may be implemented in a limited way that does not go to scale across the population at risk for lack of resources. On the average, it sometimes takes up to 17 years to successfully implement an evidence-based intervention, and only 14% of interventions reach their target group, depending on where the intervention was developed and where it was applied. Oftentimes, the peripheral level primary care providers in Nigeria do not have the tools needed to improve outcomes and deploy evidence-based interventions that are most needed at that level of care. Since most Nigerians seek health care at that level, researchers, you and I, in our educational and health institutions, must now prioritize implementation science research over basic and epidemiological research endeavors, as it offers rigorous methods to address the barriers that hinder and facilitators that support uptake of proven healthcare interventions, speeding up the translation of research into practice. And that's usually the implementation of research for evidence framework. You must reach the necessary community, you must talk about effectiveness, then adoption, then implementation, and then maintenance. So you can see why it takes so many years sometimes for new interventions to be completely adopted and implemented. If we invest better in implementation research over epidemiologic and basic research today, it will offer a critical pathway for strengthening the key health programs of Nigeria by addressing persistent gaps between evidence and practice, applying locally developed and context-specific research evidence that overcomes the obstacles of deploying evidence from distant climes. I know for the number of years that our sitting Vice Chancellor was implementing the kangaroo mother care, to the care of newborns. That implementation science for research evidence was not developed in Nigeria, but at least it was brought here for implementation, and I knew she was at the helm of affairs of, implementing that. We had the IMCI. IMCI worked in many countries of East Africa. It reduced child and infant mortality very, very significantly. We've not been able to deploy at scale to reduce the same mortality statistics in Nigeria. I think it's high time we sit down and look at serious implementation science research that can help our own health system. From maternal and child health approaches to mental health interventions, the need for easily deployable implementation science research outputs drums louder today and more than ever before in Nigeria. It's a panacea for massive development of evidence-based interventions at scale. We must leverage technology and innovation for transformative change. As I'm drawing closer to the end of this is very important. As Nigeria seeks to reimagine its healthcare system, the integration of technology and innovation holds immense promise. Experts have highlighted the potential of leveraging artificial intelligence and digital solutions to address some of the most pressing health challenges that include coordinating healthcare records. By aggregating and digitizing patients' records, healthcare providers can access comprehensive information, reducing the need for duplicate tests, improve continuity of care from the referring to the referral centers, and this currently is being rolled out in many public centers under the National Healthcare Sector Renewal Investment Initiative, and we must give that to the federal government. Even in my own health center at LA in Ile-Ife, we've deployed electronic health records, as the entire hospital is trying to do. And I want to believe the teaching hospital here at UNIMED will have started. If they have not, they must be on the way to deploying the electronic medical records. Triage and remote care. AI-powered triage systems can help identify and direct patients to the appropriate level of care, reducing the burden on tertiary healthcare facilities. Because by just triaging remotely, you know where to send the patient. Every primary healthcare patient would then not end up in the teaching hospital. Additionally, telemedicine and remote consultations can expand access to specialized care, even in underserved areas, so that specialists from distant lands and from their diaspora will be able to offer their own expert knowledge. This has to be pilot tested for evidence. And thirdly, enhancing healthcare worker capacity. Relevant technology can support and empower healthcare workers, providing them with the tools and resources they need to deliver more efficient and effective care. This can help address the shortage of healthcare professionals and improve satisfaction, potentially reducing the brain drain. However, experts also have to caution that integration of technology must be carefully regulated and implemented to ensure that it complements and enhances rather than replace the human elements of care. Commit to locally funding HIV and AIDS control and health sovereignty in the supply chain for pharmaceuticals and other healthcare products in Nigeria. The federal government of Nigeria has already taken a very important step with the launch of the 62 billion HIV Trust Fund in 2022, a private sector-led initiative designed to support prevention of mother-to-child transmission and sustain the national response. However, the trust fund must be fully capitalized, transparently managed, and integrated into a broader medium-term national HIV funding plan that aligns with the UNAIDS recommended pathway of 2/3 domestic funding of HIV. Nigeria should commit to progressively increase domestic allocation to community-led and key population-led organizations, including multi-year funding agreements that are protected from short-term political changes. Sustainability also requires that HIV services should no longer operate in isolation. Nigeria's universal health coverage agenda, that is the basic healthcare provision fund, the health insurance expansions, and the social protection schemes must explicitly integrate HIV prevention, testing, and treatment. These platforms should also include sexual and reproductive health service, particularly for adolescent girls and young women, mental health care, and psychological support for persons living with HIV. By prioritizing domestic funding of translational research endeavors and interventions, strengthening accountability mechanisms, and directing resources to promising community-led organizations, Nigeria will not only safeguard its HIV response, but will also demonstrate a clear commitment to resilience and health sovereignty in the supply chain policy for pharmaceuticals and other healthcare products in an increasingly uncertain global landscape. Adoption of a gender-responsive and equitable approach. We must integrate a gender-responsive and equitable lens into the redesign of the healthcare system to address the unique needs of women and girls and improve the nation's health outcomes. This approach should be embedded throughout the healthcare ecosystem, from policy formulation to service delivery. Key elements of this strategy will include ensuring that women's healthcare needs, including sexual and reproductive health, are prioritized and adequately funded, addressing social determinants of health that disproportionately impacts women, such as gender-based discrimination in the access to education and employment, gender-based violence, financial restrictions, and cultural barriers to accessing healthcare, strengthening the capacity of healthcare institutions to provide gender-responsive care with a focus on improving maternal and child health outcomes, and engaging women, particularly those from marginalized communities, in the decision-making processes and the design of healthcare interventions to ensure their voices are heard and their needs are met. There must be intentional and objective indicators to measure the integration of such gender-responsive interventions into the healthcare system at all levels. Efficient and effective economic management. Brain drain has been identified as a product of structural inequality in the political economy of our country. Where those who control political power aggregate economic power to themselves through corruption, and corruption is the abuse of public trust for private gain. It's about time. Corruption is about the fastest means of accumulating quick wealth in Nigeria today. Corruption occurs in many forms, and it has contributed immensely to the poverty and the misery of a large segment of the Nigerian population. On the contrary, absence of corruption encourages investment and efforts to expand the pie rather than merely fighting over the distribution of the pie. To this extent, improvement in governance in general and reduction of corruption in particular could be a means to accelerating the process of development. Hence, enthronement of good governance anchored on the principles of the rule of law, high level of integrity, transparency, probity, and accountability becomes an imperative for us to curb the many ills of the health system. Breaking the infamous spine of hasty generalizations, there is hardly any country in the world that is naturally and irretrievably poor. The poverty of any country is largely premised on the particular method, structure, and policy adopted by the country's principalities and power in the division of the natural resources, being their commonwealth, and human capital being the currency to grow. The major challenge of developing countries is rooted in the mismanagement of their available resources, both natural and human. Nigerian leaders must disembark from endless wasteful resources and tolls, curtail corrupt chases, blot out the infirmity of ethnic chauvinism, resist the lure of personal aggrandizement, and bring every perpetrator of misappropriation of embezzlement of public funds to book. It cannot be gainsaid that infrastructural development is an essential ingredient of social and economic stability. To buttress this assertion, the World Bank estimates that every 1% spent on infrastructure will lead to an equivalent 1% increase in GDP, which gives a positive correlation between infrastructure and GDP. Unfortunately, Nigeria's poor infrastructure has spiraled into a cancer. In the 1960s and 70s, Nigeria, Taiwan, Singapore, and Co. had similar GDP per capita, but today, those countries have by far exceeded Nigeria in growth due to increase in their infrastructural development and total productivity. They have also become countries of destination for our immigrating health professionals and patients who can afford the cost of care. In the 70s and 80s, the Naira was stronger than the US dollar and many other foreign currencies, often exchanging for $1 to 75 kobo. This provided a lot of incentives for other nationals and expatriates to take up appointments in Nigerian institutions and provide the needed diversity for sustainable growth and development. Today, however, the Nigerian Naira has not only lost its value against the dollar, but has become a nightmare to the carriers of the Naira, having totally lost its bargaining strength to other currencies. This characteristic exchange rate crisis is a strong catalyst for mass exodus of health professionals, and operators of our fiscal and monetary policies must rethink and rejig those systems to give more market value to the Naira in order to gain international competitiveness and appeal. Lastly, the very last point, entrenchment of social justice and consequent management with an overhaul of the current constitutional regime. I'll just go to the overhaul of the constitutional regime and leave the issue of entrenching social justice to save some minutes. Given that the machinery of state is human, okay, let me move to the next paragraph. While successive national assemblies of the Fourth Republic have over the years attempted the birthing of a new workable constitution, which has led to the first, second, third, fourth, and now the fifth alterations of our 1999 Constitution. All of these still remain window dressing, as the foundation or origin of that Constitution remains very faulty. As you may recall, what we call the Constitution of the Federal Republic of Nigeria today was birthed by the Constitution of the Federal Republic of Nigeria Promulgation Decree 24 of 1999, which came into effect on May 5th, 1999, whereas the Fourth National Assembly was commissioned and was inaugurated on May 29, 1999. So our Constitution predated the National Assembly that is supposed to create and promulgate on the Constitution. You can see the problem therein. So this was 24 days after the decree came into effect. So the critical question that remains is, who are the people referred to in the preamble to that constitution that says, we the people? Could we the people be referring to the members of the General Abdusalam Abubakar Supreme Military Council, or General Abdusalam Abubakar himself? After all, Yorubas will say, "Ẹnìkan kì í jà wádé," loosely translated to mean no singular person can assume the pronoun we. Therefore, if anything is to be done to what we currently refer to as the Constitution of the Federal Republic of Nigeria, then it must start from tightening the lies told against the Constitution itself. With the benefit of hindsight, the 1999 Constitution was promulgated by the military regime of General Abdusalam Abubakar after the Constitution Debates Coordinating Committee led by Justice Toby submitted a report. Besides the fact that this committee barely had 2 months to consult with Nigerians before submitting its report was merely advisory and cannot by any means of argument answer the question, who are the we? A lot of untruths and misplacements abound in our present constitution. For example, Section 2.2 of the Constitution describes Nigeria as a federation, when in actual fact, it's a unitary constitution. How can a country be a federation when the entire property in and control of all minerals, mineral oils, and natural gas in, under, and upon any land in Nigeria, or in, under, or upon any territorial waters, and the exclusive economic zone of Nigeria is vested in the government of the federation? What is then left for the component units known as the states? The effect of this is that all states queue at the Federal Capital Territory on a monthly basis for handouts, rather than states contributing to the center in a true federation. This is the beginning of our economic woes, which is sending Nigerians fleeing the country in their droves. The power is over-centralized, only few people are benefiting. When the powers are devolved to the regions and the states, then we can begin to monitor how the resources are spent. It can reach many more people, and many more health workers can be employed and justifully engaged and paid the right amount of money. In terms of security, how do we have a federal government with federating states, where the governors do not have any jurisdiction or power over the security systems or apparatus in their state? Yet a governor is casually labeled the chief security officer of the state. He does not appoint the commissioner of police in his state, as all he hears is the deployment of a commissioner of police to his state. He has no say even in the deployment. We should stop deceiving ourselves by sending commissioners of police from any state in the north to the southwest or to the southeast, or vice versa, when such police commissioners have never been to such places before or have any idea of knowledge of the language or dialect of the people. How then does he communicate or enforce security? Nigeria is too big and large a country for a constitution to pretentiously foist on us a single police command under the aegis of the Inspector General of Police. The last explosion at Ibadan 2 years ago, as a result of house-wearing and stocking of explosives meant for mining purposes, should serve as an eye-opener. Several lives and properties were lost. The federal government issued the mining licenses without the knowledge of the governor. But the governor was, or he still the one being abused, accused, and lampooned by the citizens for the Gori incident. Simply put, our own federal constitution is an aberration, and it is high time we drafted a new constitution for the federating unit by the people themselves. Conclusion. Reimagining Nigerian healthcare system is a critical and urgent task that requires a comprehensive, multi-stakeholder approach. The health workforce attrition crisis constitutes an existential threat to health security and institutional resilience. The simultaneous loss of younger professionals through migration and experienced workers through retirement creates a double depletion effect, weakening both current service delivery and future leadership capacity. A multi-pronged approach combining managed migration frameworks, enhanced remuneration, improved working conditions, and targeted primary healthcare workforce expansion is urgently required to prevent catastrophic deterioration of the nation's health security architecture by addressing the fundamental gaps in health funding, human resource management, gender-responsive care, health policy and legislative enactments, health research priorities, economic management, and relevant constitutional provisions. Nigeria can build a healthcare system that truly works for all citizens, leaving no one behind. Madam Vice Chancellor, in this lecture, I have tried to draw a clear roadmap for transformative change, emphasizing the need for bold and decisive actions at several levels. I've shown that with a renewed commitment to healthcare as a national priority, Nigeria can leverage technology, innovation, and a gender-equitable approach to deliver quality, accessible, and affordable healthcare to its people. This is not just a moral imperative, but a crucial step towards a healthier, more prosperous, and more equitable Nigeria. Acknowledgements. I wish to acknowledge the immediate past Vice Chancellor of UNIMED, the person of Professor Adesegun Fatusi, who provided me with some of the materials cited, especially the autobiography of Baba Akinkugbe, and many of the materials cited in the bibliography section, which proved quite instructive in the preparation of this lecture. All materials consulted and from which useful information was extracted have been equally and fully listed in the bibliography section, and I duly acknowledge and thank the various authors and organizations. Once more, Madam Vice Chancellor, distinguished audience, I want to thank you for this invitation, and I thank you all for listening.
Please, let's keep clapping for him until he sits. Thank you very much. Wow. What a value for our time. And I want to believe that if at the moment when he started, and he first gave a glowing tribute to Baba, I kept on wondering, where would this one lead us to? What Prof did now, Prof just spoke more like a doppelganger of Baba himself. It's like Baba was talking to us. He did it in such a manner that you will know that he's a clinician, first and foremost, and also a thoroughbred researcher. Indeed, professor of community medicine, the combination, the way he painted a very gory picture at the beginning when he was doing the comparative analysis between this country, what we experience, and compared to nations of the world that are more populated even than Nigeria, when he gave the instance of India and China. And then I kept on wondering, if these people are this many, and we are not up to them, and we are facing these challenges, then what there will happen? And I put something down that, you know, when a speaker is talking to you, somebody who knows his onions, he will not just paint problems to us, he will also profile solutions. And Prof advocated in the course of talking to us, saying he advocated for far-reaching reforms in health financing, in human resources, and he also gender-responsive health care, health policy, legislation, research priorities, economic management, and relevant constitutional provisions. Sincerely, when he got to the issue of constitutional provisions, I asked myself, is Prof also a political scientist? This is somebody that understands a little about almost everything. I describe the lecture as being eclectic, picking from here, picking from there, becoming a whole that all of us can actually relate with. Ladies and gentlemen, please once again, let's put our hands together for Professor IJADUNOLA. Thank you very much, sir. Thank you very much, sir. In addition to that, to tell us that we are not just alone here. We have several people that joined online and they are still there. This is the, Madam Vice Chancellor, this is the comments of the former governor of this state, the one who established this institution, about what we are doing. He stayed glued from the beginning till the end. He's still online. And he had this to say. Congratulations to the Akinkugbe family and to UNIMED for sustaining this celebration of excellence. I think the governor deserves a round of applause. This is a legacy that we don't want to die, and it will not die. That was what the VC told me earlier today. And you can see what is happening here. Ma, thank you very much for sustaining this legacy. We are going to entertain one or two questions, basically two comment or questions, so that what we are doing here will not be like a monologue. We want to take one or two feedbacks, if any, but before that, we have in our midst a teacher of teachers, a teacher of mass communication, well known across the four corners of the society, the man who is, if I'm correct, Prof is like 85 years now, and he's still in class teaching. He's a man some of us have referenced his works in most of our papers. Ladies and gentlemen, please a round of applause for the Deputy Vice Chancellor, Administration, Wesley University, Ondo, Professor Dayo Duyile. Thank you, sir. Thank you for joining us, sir. We have the highest regard you may think of. You are our teacher, either directly or indirectly, and we respect you. Thank you, sir. Ladies and gentlemen, do we have questions, comments? We just want to entertain too. Sir, you are number one. Any other one? If that is, oh, what do? I want to plead with Mr. Jude, because I just want to take two, to allow me to honor Professor Duyile, who has also raised his hand. And I will ensure you speak to the speaker directly. You have that honor. One-on-one. Thank you. Sir.
The Vice Chancellor, the distinguished guest lecturer for today, the family of our Emeritus Professor. Mine is not a question, but just a comment, and it's just my take-home from the very thought-provoking lecture of today, that if we are to improve health outcomes in Nigeria, we need to adopt a cross-cutting, multi-sectorial intervention that is not limited to the health sector alone, because you have highlighted the interplay between the broader microeconomic security and infrastructural reform. So it has to go beyond this room. It must be cross-cutting. Thank you very much.
Now we take Prof. Thank you.
Standing on the existing protocols, Mr. Vice Chancellor, sir, and the distinguished lecturer, I've listened to your lecture, which is well-researched topic on the health sector of this country. But I noticed that there's a missing point. In any development, healthcare development in any country, the media play a lot of great roles in trying to distinguish between good health, bad health. And the policy of government is orchestrated in the media throughout. There is no country in the world that pushes aside its media. In this lecture, it is glaring that you have not mentioned any role that the press should play in disseminating healthcare messages to the rural areas. I appreciate your references to rural health care. And I'm aware that this country has a lot of health workers divided into segments: the medical, the nursing, the community workers, community health workers, the pharmacists, a lot of them. There is a lot of difficulty in harnessing the functions of all this to achieve what you have just advocated. My respectful lecturer, sir, would you like to talk about the role of the media in this particular assignment? Thank you very much.
Only one question.
Just the angle. Madam Vice Chancellor, the Akinkugbe family, distinguished audience, I must defer to you, sir. I must defer to you that that was a large omission. But you will understand with me that in a lecture of 30 minutes that I prolonged to 1.5 hours, I guess, or 2 hours, I would definitely have some oversight and not be able to touch on every, but talking seriously, we cannot underplay or underestimate, or overestimate is the word. We can never overestimate the role of media in disseminating health information, health education, and the health policies and programs of government in any country. Yes, only yesterday, in my master's class, I was teaching behavior change communication interventions in the control of HIV. Professor Adejugbe and myself used to co-teach that course. And what's behavior change communication? It's all about what the media does. So I defer to you and I apologize, and I say the media has a very, very big role to play, either in terms of disseminating the policy of government or reaching directly or indirectly the people for whom the services are meant. The media plays an intermediary role, you know, between the health system and the people for which, and we can never, ever overestimate the role of the media. I'm sure if I have another opportunity to give this lecture again at Wesley University, I'll probably prioritize that. Thank you, sir.
Thank you very much. We appreciate the comments and the question raised by Prof. And Prof, we have also put in place mechanisms to ensure that whatever we are doing here today does not end here. You can see the microphone in front of us. That's Arise News, and several newspapers are also in the house to actually push what we are doing. And I can assure you, in the next 2 to 3 hours, this will dominate the media space. That we can assure you. And the point also you raised is well noted, particularly in development communication. Thank you very much, sir. Please a round of applause for the people who have passed the comments. At this point, we are gradually getting to the end of the program. And as our practice here, we don't allow people to come here and go empty-handed. We want to appreciate the guest lecturer for coming. We have something to present to you, sir. He has always been a friend of this university for long. But today, we also want to formally induct him as a friend of UNIMED. And I want to respectfully call on the Vice Chancellor to do this for us. And with the permission of the Vice Chancellor too, I want to call on Mr. Olu Akinkugbe to join the Vice Chancellor in this exercise.
Okay. I'm sure we all, please have a seat, have your seat. We all agree that
we couldn't have been a better person that would have delivered this lecture. It was in his elements, because it's a very familiar ground for him. You had the citation. So, I mean, that shows that we got the right peg in the right hole. And as he was saying, I remember a story, 2 stories. 2 young doctors went to the pharmacy because of, I'm talking about behavior seeking, you know, what we do. And they went to the pharmacy because they were doctors. They went to collect drugs. They got there, they wanted to buy Septrin. And so the vendor there gave them Combantrin. And they said, no, we want Septrin. He said, yes, they are all trin. You know? The second one is a very senior colleague who somewhere in Oyo State went home in his village to go and see his father. And he saw a lot of people gathered in front of their house. And he was wondering, what's happening? And he saw a young man that was in the middle, and he had a weighing scale, you know, and he put it there. And if you climb it, you know, the red, as the thing deflects, he said, that is your blood, though. That's your blood that is moving up and down. And he gave them drugs. Yeah, he gave them drugs. So you can imagine what is happening in our in the ecosystem. Yes. So I want to thank you, Professor IJADUNOLA, for this wonderful, well-researched discussion. I'm sure that there's something that has happened to each one of us, something to think about, what to do, you know, how to come in. And as we've been said too, this is going to the media. I hope somebody somewhere will also use this and to make a difference in our country. So on behalf of UNIMED, I want to decorate you as a friend of UNIMED. Thank you. And in addition, this is a word of appreciation presented to Professor KAYODE IJADUNOLA, our guest lecturer at the 5th Emeritus Professor Oladipo Akinkugbe Distinguished Lecture, holding today at our third floor, University of Medical Sciences, Ondo City, Ondo State, the 14th of July, 2026. Congratulations.
Please let's put our hands together for the Vice Chancellor and Mr. Olu Akinkugbe.